According to the International Agency for Research on Cancer, global cancer cases are actually projected to reach 35 million by the year 2050, which is just, it is a staggering number. But when you look really closely at oncology, the hidden danger isn't even just the disease itself, it's the polypharmacy.
Right, the sheer volume of drugs.
Exactly. We are talking about patients taking a median of 6 medications simultaneously, and over 11% of these patients are taking 11 or more drugs at once.
And honestly, the mathematical permutations of, 11 different pharmacological agents interacting in a single human body, it's completely beyond the cognitive capacity of any physician to predict.
Yeah.
Traditionally, discovering an adverse drug interaction or a DDI meant just waiting for post-marketing surveillance.
Just waiting to see what happens.
Pretty much. You essentially wait for a statistically significant number of patients to experience severe toxicity in the real world, before flagging the combination.
Which is a terrifying way to do medicine, right? And that brings us to the core of what we are unpacking today. We're doing a deep dive into a 2026 systematic review from NPJ Precision Oncology that details this massive shift in how we handle these biochemical collisions.
It really is a paradigm shift.
Yeah, we are moving away from reactive observation and toward proactive algorithmic simulation using machine learning and deep learning. Okay, let's unpack this. How big of a change is this, really?
Oh, the transition is monumental. These models are essentially ingesting the entire known universe of pharmacological data, right? And they do this to simulate molecular interactions before a prescription is even written.
Wow.
Yeah, they are mapping overlaps in metabolic pathways that human researchers would literally take lifetimes to chart out manually.
Right, because before we can understand how AI predicts, like a biochemical car crash, we need to understand how the traffic system works inside the human body.
Exactly.
For anyone who follows pharmacology, you already know the high stakes of pharmacokinetics and pharmacodynamics, but let's break it down really quick.
Sure. So pharmacokinetics, or PK, is basically what the body does to the drug.
Right, and a great way for you listening to remember this is the mnemonic ADME. ADME.
I love that one.
Yeah, it stands for absorption, distribution, metabolism, excretion. Think of it sort of like a massive shipping company, getting the package in, routing it to the right department, using the contents, and then taking out the trash.
That's a perfect analogy. And the crucial detail here involves the workers in that shipping company. You have transporters like PGP and OATP, which act as the delivery trucks. And then you have enzymes like the CYP450 family, which are essentially chemical shredders.
Shredders, right.
Yeah. So if you take drug 1, it might need that shredder to be processed. But if you add drug 2 into the mix, drug 2 might completely block or even supercharge those CYP450 shredders.
Which completely alters the concentration of the first drug.
Yes, exactly. And then you have pharmacodynamics, or PD, which is what the drug does to the body. That's when, say, drug 2 physically blocks drug 1 from attaching to its target receptor, or it just messes with the signaling pathway altogether.
And the margin for error we're dealing with here, especially with what we call NTI, narrow therapeutic index drugs, is just razor thin.
Oh, absolutely.
It's like walking a tightrope. A millimeter step to the left, meaning too little of the drug, and the cancer grows. A millimeter to the right, meaning too much drug, and you trigger a fatal toxicity.
The clinical literature is honestly full of these catastrophic miscalculations. Like, take the combination of 5-fluorouracil, which is a heavily utilized cytotoxic drug that walks that exact NTI tightrope, and combine it with soravudine.
Soravudine is an antiviral, right?
Right, but it happens to irreversibly bind to and inhibit the specific enzyme, DPD, that is responsible for catabolizing or shredding the 5-fluorouracil.
Oh, wow. So it breaks the shredder.
Exactly. The moment that enzyme is knocked offline, the clearance of the cancer drug just halts. It accumulates exponentially in the plasma, and that leads directly to fatal bone marrow suppression.
That is terrifying. And, it isn't always two exotic specialty drugs colliding. You see the exact same dynamic with something as ubiquitous as methotrexate.
Yeah, the blood cancer drug.
Right. Being taken alongside standard, everyday NSAIDs, like ibuprofen.
That's a classic example, because methotrexate clearance relies heavily on specific organic anion transporters, or OATs, in the kidneys.
The delivery trucks.
Exactly, the trucks taking it out of the body. But NSAIDs aggressively compete for those exact same transporters.
Yeah.
They create this massive biochemical traffic jam at the renal exit point.
Right, so a low, normally safe maintenance dose of methotrexate suddenly gets trapped in systemic circulation.
And it transforms a completely safe therapy into a severe, life-threatening adverse event.
Okay, so let's just do a quick mini recap before we move on. First bullet. PK is ADME. That's the body processing the drug, the shipping company. Second bullet, PD is the drug actually hitting the target. And third bullet, NTI drugs are tightropes where DDI slip-ups are literally fatal.
Spot on.
So for you listening, think about the last time you took 2 different medications at the same time. Did you ever wonder if one was secretly turning off the shredder enzyme for the other one?
It's something most people never even consider.
Right. But if human doctors can't possibly cross-reference 11 different molecular structures against thousands of metabolic enzymes in real time, how exactly does a computer do it?
Well, the architectural foundation for almost 3/4, I think 72.9% of the models in this systematic review relies on deep learning, specifically graph neural networks, or GNNs, and graph convolutional networks.
Okay, that sounds intense.
It is, but they operate on what we call knowledge graphs.
Now, whenever people hear knowledge graph, I think the default is to imagine a basic social network map, right? Like, John is friends with Mary.
Right, that's the basic concept.
But in this biological context, it's vastly more complex. It's saying, like, drug A, which is a node, inhibits enzyme B, which is an edge, which then metabolizes drug C, another node.
Exactly. It's a massive, highly interconnected social network for biology. The nodes are drugs, proteins, diseases. And the edges are highly specific mechanistic actions, inhibits, induces, upregulates.
Here's where it gets really interesting, though. I saw that they are now merging large language models into these knowledge graphs.
Oh, yeah. Models are now utilizing the semantic understanding of LLMs to read unstructured medical literature, find new relationships that no one has mapped yet, and literally weave those new connections into the knowledge graph dynamically.
That is wild. But where does the baseline data come from? Because an AI is only as good as its training data.
The primary engine is DrugBank. It was used in about 67.8% of the studies they reviewed. They also use databases like 2Sides for side effects and KG for intricate cellular pathways.
Okay, so the AI has this massive database. What are the actual features it looks at? Like, what does the drug's resume actually look like to the AI?
The resume is generally broken down into 4 main categories.
Yeah.
First, you have biological features. Those are the targets, the enzymes. Second, phenotypic features, which are the clinical side effects. Third, network features, literally where the drug sits in that massive social network we just talked about.
Okay, and the fourth?
Chemical features. This is the structural, physical shape of the molecule. It's usually represented mathematically by something called a Morgan fingerprint.
A Morgan fingerprint?
Yeah, it basically translates a 3D molecular structure into a dense binary vector, like a string of ones and zeros, so the AI can mathematically compare the shapes of different drugs.
Interesting. So logically, if I'm designing this AI, I'm feeding it every single feature, every part of the resume.
Right.
More data equals better accuracy.
You would think so. Yeah. And generally, combining features does work best. Chemical structure is still the undisputed king of information, by the way. But a fascinating nuance came out in one of the studies. It showed that throwing all the features together doesn't always win.
Wait, really? Why not?
Well, if a drug targets only one highly specific pathway, adding a ton of broad biological pathway data actually just adds noise. The AI gets distracted by irrelevant info.
Ah, I see. It loses the signal and the noise.
Exactly.
Okay, time for another quick check-in. Bullet 1. Deep learning and GNNs map out biology just like a massive social network. Bullet 2. The AI reads a drug's resume using chemical, biological, and network features. And bullet 3. DrugBank is basically the ultimate AI training ground.
Perfect summary.
So, question for you listening. If you were an AI, would you rely more on a drug's chemical shape or the friends it hangs out with in the body's network?
That's a tough call, honestly.
It is, and it brings up a huge issue because it's pretty easy to predict something when you already have the answer key, right? But how do these models perform in the wild with brand new, never-before-seen drugs?
This is where we hit the most significant hurdle. In the literature, they grade these models using 3 distinct predictive tasks.
Okay, break those down for us.
Task 1 is transductive. That means both drugs are already in the training set. It's an open book test.
And I'm guessing the AI aces that.
Oh, absolutely. AI scores an A+.
Sure.
Accuracy is over 0.88. AUROC is over 0.99. It's phenomenal.
But then
you get to tasks 2 and 3, which are inductive, meaning one or both drugs are entirely new to the AI. And the harsh reality is performance just plummets.
How bad of a drop are we talking?
Sometimes accuracy drops from nearly 90% down to 0.40.
Wow. That's literally worse than flipping a coin.
It is.
But why? If it learned the rules of biochemistry, why can't it apply them to a new drug?
It comes down to a really deep mechanism called the negative sampling problem. Think about it. How do you teach an AI that two drugs don't interact?
I mean, you just show it drugs that don't have interactions, right?
But our databases only record the interactions we've found.
Yeah.
Just because no one wrote it down doesn't mean it's safe. It just means nobody tested it yet.
Oh, right. So you can't just assume a blank space is a safe combination.
Exactly. But historically, researchers took the lazy way out. Random sampling. They just picked two unlinked drugs and told the AI, these are safe.
Which is feeding the AI false information.
Right. So they tried a mathematical fix called average Euclidean distance, or AED. The idea was if two drugs are mathematically very far apart in their chemical structure, if they look completely different, they probably don't interact.
Wait a second, let me push back on that. If two drugs look totally different chemically, is it really safe to assume they don't interact? What if they just bump into the exact same protein target by coincidence?
What's fascinating here is, you are absolutely right, that's the exact flaw. Take nifedipine and verapamil. Chemically, they are super distant. They look nothing alike. If an AI relies purely on chemical distance, it assumes they are safe to mix. But clinically, they both block L-type calcium channels in the heart.
Oh, wow. So if you mix them, you get a massive compounding effect.
A huge hypotensive crisis. Relying on chemical distance causes the AI to completely fail.
So how do you fix that? How do you solve the negative sampling problem?
They introduce some incredibly advanced fixes, specifically something called PU learning, positive unlabeled learning.
Positive unlabeled, what does that mean?
Instead of assuming an unknown drug pair is a definite negative, it treats it as a probability. It mathematically acknowledges that the unlabeled data contains hidden, undiscovered interactions.
It acknowledges what it doesn't know.
Exactly. And by doing that, it pushed the accuracy on new drugs all the way back up to 0.96.
That is brilliant. Okay, let's recap this section. Bullet 1. AIs ace tests on old drugs, but really struggle with brand new ones. Bullet 2. Proving a negative that a DDI doesn't exist is basically the hardest math problem in the field. And bullet 3. PU learning is saving the day by calculating probabilities instead of absolutes.
Nailed it.
So, for the listeners, how would you teach a computer the difference between we haven't discovered the interaction yet and it definitely doesn't exist? It's a huge philosophical and mathematical puzzle.
It really is.
So we built this incredibly complex AI with PU learning. Did it actually uncover anything we didn't already know? Did it find real-world triumphs?
It absolutely did. The systematic review took the AI's novel predictions and actually checked them against real-world clinical databases as of March 2026.
And
the AI found 96 newly predicted DDIs, and of those, 22 have already been verified in the real world.
Wow, so the AI predicted a car crash and then the clinical data proved it actually happened?
Yes. And crucially, 10 of those verified interactions were categorized as major severity.
That's huge. Give us an example. What did it find?
Okay, case 1, regorafenib combined with cisplatin.
Okay, cisplatin is a heavy-duty chemo, right?
Very heavy duty.
Yeah.
The AI flagged this combo. Why? Well, both drugs are known to independently cause hepatic or liver toxicity. So combined, it's not a metabolic traffic jam, it's just a massive compounding double punch to the liver.
Yikes. So it caught a compounded pharmacodynamic issue.
Exactly. But it also catches sneaky pharmacokinetic traps, like case 2, niraparib and phenytoin.
Niraparib is for ovarian cancer, I think.
Right. And it's metabolized by the CYP3A4 shredder. Now, phenytoin is a common seizure medication.
And cancer patients often get seizures from brain metastases, so that's a super common combo.
Highly common. But phenytoin is a massive CYP3A4 inducer.
Oh, no. It turns the shredder on hyperdrive.
Yes. It turns the shredder on hyperdrive, literally destroying the ovarian cancer drug before it can even reach the tumor to save the patient's life.
That is terrifying. It's a silent failure. The cancer grows, and the doctor might just think the chemo isn't working.
Exactly, when in reality, the seizure med is just eating it up.
Okay, so what does this all mean for the future? Because everything we've talked about so far involves small molecules. But the future of oncology is biologics, right?
Right, large complex therapies like monoclonal antibodies.
How does the AI handle those?
Well, out of the 112 drugs in the newly identified DDIs, almost all were small molecules. Biologics are a huge problem. They aren't simple chemical structures you can turn into a Morgan fingerprint.
They're massive amino acid sequences?
Exactly. And they don't even use the CYP450 shredders in the liver. They degrade differently.
So they don't cause these interactions?
Mostly no. But there is a massive exception. Cytokine modulators, like tocilizumab.
How does that one work?
It suppresses IL-6, which is an inflammatory protein.
Right.
But IL-6 naturally suppresses the CYP3A4 shredder.
Wait, let me follow this. The biologic suppresses IL-6,
Right.
which was suppressing the shredder. So without IL-6, the shredder wakes up.
It wakes up, it goes crazy because a domino effect.
Yeah.
So if you were on a small molecule drug like simvastatin, the awakened shredder suddenly destroys it.
Wow. So the AI has to map that out.
Yeah, and standard chemical features can't do it. AI is just now beginning to learn how to map 3D amino acid contact maps to predict these insane domino effects.
That is just mind-blowing. Okay, mini recap time. Bullet 1. The AI successfully predicted 22 real-world DDIs, including the dangerous regorafenib and cisplatin double punch to the liver. Bullet 2. Seizure meds can literally eat up cancer meds by supercharging the shredder. And bullet 3. Massive biologic drugs require totally new AI mapping techniques. So, question for you listening. Given how fast AI is finding these deadly combinations, do you think every prescription in the future will have to pass an AI check before it even reaches your hands?
I mean, I certainly hope so.
But as we pull all this together, there's one glaring blind spot in this entire paradigm. The AI is brilliant at looking at the drugs, right? It sees the enzymes, the pathways. But what is it missing?
It's missing the patient.
The actual human being.
Right. We urgently need to integrate electronic health records, or EHRs. We need the patient's age, gender, kidney function.
And their genetics, right?
Exactly. Genetic polymorphisms. Your specific genetics dictate how fast your personal CYP450 enzymes run.
So a drug combo that is perfectly safe for me might be completely fatal for you.
If we connect this to the bigger picture, an AI that only looks at a molecule is like a mechanic who only looks at a spark plug but completely ignores the engine it's going into.
That is such a profound way to look at it, and it leaves us with this final, truly provocative thought to end on.
Yeah.
Right now, we're using these AIs as guardrails, basically helping doctors avoid making terrible mistakes.
Yeah.
But extrapolate this into the future. Imagine an AI that doesn't just say, hey, don't mix these two.
Right.
Imagine an AI that looks at your specific genetics, your specific tumor, and says, because of your unique biology, this exact wildly counterintuitive combination of 3 toxic drugs will uniquely cure your cancer.
A completely bespoke cure generated by a machine.
Exactly. It makes you wonder, are we ready for an era where a machine understands our biochemistry so deeply that it knows us better than our own doctors do? It's something to think about. Keep diving deep.